My name is Dr. Alison Stewart, and I've had an interest in looking after patients and the treatment of patients who have viral hepatitis C for more than a decade. It's a passion of mine and a special interest of mine. The reason I'm doing this presentation today is because the treatment of hepatitis C has been revolutionised over the last couple of years. And there are now new drugs that make the treatment of hepatitis C simple, they're very effective, and GPs are now part of that revolution and are able to treat in their own surgeries. Since the new direct-acting antiviral treatments have been available, thousands of people with hepatitis C have been successfully treated. But there has been a bit of a slowdown in the rate of treatment, and this presentation is really about seeing whether we can reach out to the potentially thousands of people in our community who have been undiagnosed and untreated. This is really a quick guide to being able to treat hepatitis C in your surgery. I've got 5 easy steps that I think summarise the approach. The first step is to establish a current hepatitis C infection. The next step is to exclude co-infection, and that's with hepatitis B and HIV. The third step is to assess the state of the liver, and that's principally to exclude advanced fibrosis. Any patient who you think's got advanced fibrosis, you can refer to a specialist clinic. The next step is to assess the patient's comorbidities and their medications, and then the 5th step is to actually choose the treatment. But what I'm going to start with is who you should be thinking about in your practice who might have undiagnosed viral hepatitis C. There are potentially 10,000 people in the Metro South Health region who have undiagnosed and untreated viral hepatitis, and this has been established on the basis of some prevalence studies. We have certainly treated thousands of people in the Metro South, but we are the area in Queensland with the highest number of people who have viral hepatitis C. So we have got to think about where these people might be and how we can touch base with them. In your own practice, you want to think about people who have ever injected drugs. The vast majority of those people will now no longer be injecting. They probably injected years ago and were part of a scene either in the 1970s or in certain music scenes in the 1980s. So 2/3 of these people are no longer injecting, and they're probably in our practices. People who've ever been in prison, and this is an independent risk factor for viral hepatitis C. People don't even need to have injected. All they have to do is have been in prison, and that's because of other risks of being in prison, such as tattoos, sharing of personal hygiene, and so on. People who have persistently abnormal liver function tests, and I know that most of you will do a viral hepatitis screen if you have people who have got persistently abnormal liver function tests. People who have an Aboriginal or Torres Strait Islander background, and certain ethnic communities have increased rates of viral hepatitis C. So from a CALD perspective, these include people who have come from Southeast Asia. Egypt is one of those countries where there is a high prevalence of viral hepatitis C. Hepatitis C is generally not considered to be a sexually transmitted infection. However, there are certain groups that are more likely to contract viral hepatitis C from sexual activity, and that is men who have sex with men. And in general, probably the biggest group of people who potentially have viral hepatitis C are men who are aged between the ages of 40 and 60. So they are a group of people in your practice that you could target to come in and have a liver checkup.